community and for the community. We have a lot to say, so I'm going to go straight to the introductions of our panelists, and then we'll start with some questions. This is going to be a very freewheeling discussion between our panelists about the key issues that we face as communities involved in trying to eliminate tuberculosis. And as you will see, our panelists are wearing masks. Many of them have been TB patients, and one of our jobs is to unmask the stigma surrounding tuberculosis. And that's one of the things we will be discussing today as a key point. So I will start with my co-facilitator, Oxana, there she is, Oxana Rucsineanu. Oxana is from Moldova. She's the founder of a TB patients organization. She spent many years educating patients, supporting treatment in the community, advocating for human rights. She is currently the Europe and Eurasia, or the European region, focal point for the Global Coalition of TB Advocates and a member of the TB Europe Coalition. So welcome.
Thank you.
She's also my co-facilitator. Oleksandr Kulchenko has been working in the non-governmental sector in Ukraine for more than 15 years. He began as a volunteer in a youth organization and then worked at a center specializing in the re-socialization of people recovering from substance abuse. In 2003, he helped establish a regional branch of the All-Ukrainian Network of People Living with HIV/AIDS. And since 2009, he served at the headquarters office in Ukraine as the focal point for all things tuberculosis. We then have Mesake Navugona. Mesake comes from Fiji, where he's a plumber by trade and works as a technical officer for Fiji's Water Authority. He's been involved with sports since he was 10 years old. And in 2000, he represented his country at the World Cup of Rugby, so don't mess with him. And he's also a former patient, so he spends a great deal of his voluntary time working with young people in sports, managing the National Rugby League teams, and he is a TB survivor and advocate who works specifically with Fiji's youth on awareness programs. Patrick Nsimba is a former TB patient from DR Congo who's been an activist in the fight against TB since 2001. He joined Club des Amis d'Amiens, where he took on the role of referring TB patients, offering psychosocial support to critically ill patients, and providing information to communities. Patrick was formerly trained as a mathematician and physicist, and he has since completed undergraduate and graduate degrees in international relations. Through this advocacy work, he's received extensive training in HIV/AIDS counseling. In 2013, he participated in the external review of the National TB Program, and he now serves as the Deputy National Secretary and Project Coordinator for SEAD and an alternate member of the Global Fund Democratic Republic of Congo, CCM, representing TB patients. So welcome to all of our panelists. And Monse Foz will serve as Patrick's interpreter. I also want to acknowledge the people who can't be here. My co-facilitator, my co-moderator was Harami Halea from Thailand and Cambodia. And unfortunately, she could not join us because of health reasons, so we send our best for her speedy recovery and hope that we will see her again soon. Edith Garba is a recovered MDR TB patient from Nigeria, and she was unable to get a visa to come to the conference. So we tried very hard, and we're heartbroken that she could not make it, but Edith very graciously sent me 8 pages of notes, so I will be trying to incorporate some of her comments into our discussion today. So as I said, this is going to be a very freewheeling discussion. It's mainly going to be a conversation between our panelists, and I'm going to try to be as quiet as possible. So I'll ask a few questions, and then we're going to try to cover all the key points that you all need to hear before you leave this room. Thank you. actually, before, is this on? Hello? Okay. Before I start, I want to actually read something to set the stage that Edith has sent to me. And this is the way it goes. The World Health Organization defines health as a fundamental human right and a social goal, the attainment of which requires a concerted action by the health sector and all other sectors of society. It's a social goal that involves communities and individuals accepting greater responsibility for promoting and facilitating health and actively participating in attaining them. However, at the core of the right to health is also the dignity of each and every person, and as such there is a need for adequate planning and implementation of effective person-centered services. According to WHO, primary health care means essential health care based on practical, scientifically sound, and socially acceptable methods and technologies made universally acceptable to individuals and communities through their full participation. The key word here is full participation and integration of the communities. So I want to thank Edith for that thought, and I would like to now ask our panelists to talk a little bit about what their experience has been in community engagement in TB in their particular countries. Just take about 3 minutes to explain the background of what you have done in your communities and why.
Okay, I guess I'll start. Well, in Ukraine, we started as a community organization, a patient organization. We started working in TB back in 2009, I would say, a little bit earlier, because we were very concerned with the high mortality rates among HIV-positive patients with TB, from TB. So we kind of superimposed ourselves onto the TB service in Ukraine. I cannot say that the TB service was absolutely happy with all those NGO people and social workers coming, knocking on their doors and asking and demanding to help them, the TB services in Ukraine. I should say that it went much, much easier in those regions, in those cities and towns where there was a well-established cooperation between the TB and AIDS services, because at the time they were separate medical services. Now, for a couple of years, they joined at the national level, not yet on the regional level. But that's how we started working. And in fact, I'd say that the HIV-positive community was the only community that started working in TB for obvious reasons, because at the time of ART availability, everything was going fine for the HIV-positive patients except the TB problem and the TB epidemic. I think we've been doing great, and I hope that eventually there will be more patient organizations of recovered TB patients, and not just HIV-positive people who are also involved with the TB epidemic.
In my country, in Moldova, we started our TB patient organization as a result of a necessity to hear the voices of the TB patients. While being in treatment years ago, I understood that there is a lot of space for increasing knowledge for TB patients, because it is absolutely necessary for patients to know their rights, to know what pills they are taking, to know what regimens are necessary to complete and to get cure from the TB. We started with peer-to-peer activities because we understood that it is easier for us as former patients to bring the information to patients who are in treatment. But we, at a point about 2 years ago, we understood that it is absolutely necessary to increase the knowledge not only for people but as well for general population. But it is absolutely unnecessary in the case we don't have political engagement. So we started step by step to go from peer-to-peer activities to start and to ask for a foundation or a platform in our country, which fortunately happened a year ago. And with common forces, with hand-in-hand activities, implying and involving national stakeholders who understood that it is absolutely and it is most easier to do things when we do it in common. And we cannot expect that a patient organization will solve all the problems. Even we are trying to do it at the level of patients. It is absolutely necessary to have political commitment to understand that any work is absolutely easier to be done, done in hand and while do any work together. This is how I see things, and this is how I hope it will work in our country, starting with the moment that we initiated this national platform of NGOs working in TB in our country. Thank you.
Thank you. Providing TB support in Fiji is a challenge. I've been involved as a TB advocate for TB for the last 3 years, and it's always been a challenge. As a well-known sports personality representing Fiji in sports, I've managed to engage the kids in the club, ranging from 6-year-olds to senior teams, and teaching them about rugby, coaching them about rugby, managing them, as well as spreading the message about TB. We have a lot of funding problems. Most of these are done on your own expenses. We look for local sponsors who can come in and assist to travel to mostly hard-to-reach populated areas. At the moment in Fiji, we are picking up in our advocacy and in our awareness program, but we need a lot of support.
Merci. Je m'appelle Patrick. Je vais vous faire rire. Je suis célèbre parce que je suis tombé deux fois de suite malade de tuberculose. Et c'est ce qui a fait ma célébrité. Mais je ne suis pas fier d'être là. Je suis là parce que nous devons parler des problèmes de la tuberculose.
Thank you very much. My name's Patrick, and I have to tell you, even if this may sound funny, that I became popular in my country because I was a TB patient for twice in a row. So that's the reason why I became popular. Of course, I'm not proud about that, but I'm very happy to be here because we will be focusing our discussions on TB.
Ok, je suis membre d'une expérience, avant d'être une association, dénommée Club des Amis d'Amiens, qui travaille aux côtés des malades tuberculeux au Congo. Et nous sommes plus dans l'orientation des personnes à suspicion de la tuberculose, dans les centres de santé des traitements. Nous sommes également, à travers ces malades, nous essayons de faire ce que nous appelons l'éducation sanitaire le matin avant la prise des médicaments, pour aider les malades à comprendre comment veiller au suivi du traitement. Et nous assurons également l'administration des dots à domicile pour des malades gravataires, et également les visites à domicile auprès de certains malades qui posent des problèmes. Et tout ça pour évidemment alléger un peu la tâche des personnels soignants, parce que nous avons réalisé que nous qui avons fait la maladie, nous comprenons mieux le fardeau de la maladie, et nous ne pouvons pas laisser toute la charge à cette communauté petite qui ne saura peut-être pas faire tout le travail seul. Voilà.
So I am part of an experience in my country. We created an association called Club des Amis d'Amiens. And in our association, we support TB patients in our country. In our activities, we focus on screening program for the disease. We work in health centers. We also focus on health education. So before the patients take their pills in the morning, we always train them, we educate them about the treatment and about the importance of keeping with the medication and with the treatment. We also support staff members in the home visits that they have to do in patients' home, and also specifically and particularly with complicated or problematic patients. And so we really help and support the health staff, because we, as former patients, we are really well aware of the burden of this disease, and we do not want to leave them all alone with this burden on their shoulders. So we want to mitigate this burden. That's why we are working and helping them and supporting them.
Thank you. Okay. I know that you've all been doing this work for many, many years, and we talked a little bit yesterday about some of the challenges, and I wonder if one or two of you can speak to some of the challenges of keeping people engaged as community members and volunteers.
In our experience, it is actually very difficult to find patients. I'll be talking mostly about the patient organization approach, because I come from a patient organization. In the TB community, because as one of my colleagues once said, that TB patients are supposed to get treated and forget about their disease, preferably, you know. And in our experience, the majority of the activists who start working in this field are, again, mostly people who come from the HIV community. We try to get involved with other people from local communities for a reason that mostly, I would say, the infection control reasons, because in our organizations we do work in TB dispensaries, and I know that many doctors would probably ask, how can you allow HIV positive people into TB hospitals to be working there? We don't. We actually demand that where we can control it, that only HIV negative personnel of the organizations work in the hospitals. While the HIV positive TB survivors can do the peer-to-peer education in their community. We're very well equipped with working with most at-risk populations. And that's, I think, and it's flying in there. I was in the session yesterday with people were saying that we should involve HIV organizations more into working with the TB patients, because all around the world the HIV community is well trained. We are doing great work in adherence for ART treatment, and I'm pretty sure we can do the same for the TB treatment. So far, I think that's the strongest point concerning the adherence and access to the most at-risk populations. The populations that are not exactly popular among general community, general population in the country.
Well, beyond these problems that Oleksandr mentioned, that it is very difficult to engage TB patients, former TB patients, in the peer-to-peer activities, I would like to see the hands of doctors and nurses in this hall. Can you raise your hands? Well, why I ask you? Because, you know, as a former patient and as a TB activist, it is absolutely for me frustrating when I'm approaching a doctor trying to speak about the TB and he's asking me the question, are you a doctor? That's absolutely frustrating, because I consider that while being from this experience, I do possess the knowledge. And in this case, I consider that patients and doctors should be very good partners, because a lot of depends on the doctors and nurses in this process. They are mostly, TB is a long treatment process. If you are fortunate, it is only 6 months, and if you are not, it is at least 24 months. And during the treatment, we either become friends with doctors, patients, or not friends. And it is, of course, more desirable to be friends with your doctor and nurses while the treatment. That's why I think that it is absolutely necessary to increase the partnership. And this is one of a vision of our organization, to increase the partners between medical staff and patients, and then go forward to patients, medical staff, and authorities. Engaging all of them in this conversation will bring a lot of benefits to all of us. And that's why I'm thinking that it is absolutely necessary to accept we as TB activists sometimes in the processes which belong to TB care. It is only to be a great benefit and bring a great benefit to all of us, to the whole society.
Before, Mesake, I'm going to ask you another question. But before I do that, I want to ask Patrick, because you've had a very different experience in sustaining the volunteers that you work with in Congo, and how have you managed to do that with the former patients?
Bon, merci beaucoup. Je crois qu'au Congo, effectivement, c'est une expérience assez particulière. Nous passons par la conscientisation de malades eux-mêmes. Donc, dès le premier contact avec l'infirmier, nous conscientisons ces malades pour leur faire comprendre que la tuberculose est un problème majeur, est une ampleur pour laquelle nous devons agir. Une fois que le malade a compris, nous essayons de faire comprendre aux malades qu'il y a une structure qui existe, composée des anciens malades, et s'il estime qu'il peut adhérer au club, il adhère, et il fait le même travail que nous. C'est vraiment du volontariat, il n'y a rien à donner. Mais seulement, dans cette séance de conscientisation, nous essayons de démontrer l'ampleur de la maladie, et facilement les amis adhèrent. Et lorsqu'ils adhèrent, ils peuvent faire le même travail que nous faisons, sans contrepartie. Ce qui est plus important pour nous, c'est de communiquer une parole à un malade ou à une personne à suspicion de la maladie. Et une fois que la personne accepte le message et il suit le traitement convenablement, à la fin il est guéri. La guérison pour nous, c'est déjà une contrepartie. Donc voilà un peu ce que je peux dire à ce stade-là. Et nous sommes parvenus à convaincre pas mal de gens à adhérer dans la structure. Et même dans notre fonctionnement, nous avons un fonctionnement de type pyramidal, un peu comme le programme national tuberculose, parce que nous avons de bons rapports avec le programme. Et je crois que le programme ne dira pas le contraire. La communauté joue une place incontournable et même de choix. Parce qu'elle est cette communauté qui est vraiment, joue le rôle d'interface entre les malades et la communauté. Et donc, nous essayons de travailler dans ce sens pour, évidemment, attirer vers la structure ou l'association toutes les personnes malades qui pensent qu'ils peuvent faire quelque chose pour l'intérêt de la communauté. Et donc, il y en a qui adhèrent. Et à l'heure actuelle, nous sommes implantés pratiquement dans 9 provinces sur les 11 que compte le Congo. Bien que bon, les défis sont majeurs, évidemment, nous n'allons pas dire qu'il n'y a pas d'obstacles. Nous avons des défis, notamment le manque d'intérêt aussi sur la question de la tuberculose. Parce que lorsque vous sortez dans la rue pour sensibiliser, ce n'est pas tout le monde qui vous accepte facilement. Lorsque vous êtes dans un centre de santé où l'infirmier n'est pas d'accord avec vous, écoutez, vous ne faites pas votre travail comme il faut. Et donc, il y a des défis énormes. Et nous pouvons aussi relever le fait que le Congo, c'est un pays post-conflit. Oui, allez-y.
Thank you very much for your question. Yes, that's right. In the Democratic Republic of Congo, we have a particular experience. We really focus on raising awareness of TB patients. That's very important for us. So, starting from the first contact with the staff members, we try to raise TB patients' awareness about the importance and about the size of this disease, which is really huge. So after this first contact, we have patients on our side, so to say. So they are screened, and if they test positive, they follow a treatment. And thanks to this first awareness that we have been given to them, they are following better the treatment, so that's very positive. And after this first contact, talking about awareness and about the importance of TB, we try to attract them and to make them become members of our club, the Club des Amis, so that they, after the treatment, they are able to work as we do, as volunteers, because everything that we do is on a volunteer basis. So awareness is very important, and we have managed to attract a lot of patients that became then volunteers. So that would be the process. So first raising their awareness, then following in a proper way the treatment, then they get cured, and they become members of our club to help the community, and that's very important. We have a pyramid structure as the NTP program, for example. It's more or less the same structure, and we try to act as our interface between patients and community. We are there in the middle to help both of them. And so we are quite well implemented. We are now present in 9 provinces out of 11 provinces that our country has. Of course, we had a lot of obstacles. We have a lot of challenges. Things are not easy, because when you go out in the street and you want to raise this awareness I was talking about, of course, we have to face a lack of interest on TB. Not everyone is interested in that. And even in health centers, when sometimes we go there and we want to tell nurses or health staff about the importance of this disease, well, sometimes they don't want to listen to us. Sometimes they are not good professional people. So that's one of the challenges that we have to face currently. And that's where I stopped him.
Okay. Go ahead.
I totally agree with Oxana in saying that the doctors and the nurses and the health workers has to work very closely with the patients. I think the former patients form a great base to spread the awareness program. Sharing my experience as a patient, I knew little about TB. When I went, I was fit. I still ran my 5 kilometers every morning. I did my weights, but I did little I don't know about TB. So when I got admitted into the hospital, then I knew about TB. So, but the program was good. I followed the dots and I've completed the program. But there is a lack there. It seems that after I've been treated, they forgot about me. I have to raise my hand and say I'd like to do some advocating and letting the age groups, the young kids, know about TB as well. And I think what the health department has lacked in my country is they've treated the disease as more important rather than the patient. I think there has to be the patient is still important, but we just have to treat. It seems that the disease is more important than the person. So there is something that we're working in Fiji and letting them know that we have to have a patient-based group that helps in the counseling, and that could relate to the patients or to other people that we are talking to.
Thank you. And okay, go ahead.
I'd like one more challenge which we faced, our patient organization, and I think every patient that get diagnosed with TB, is the language. When he get diagnosed with TB, he comes and you doctors speak to him in an unknown language. My ask is to make this language appropriate, that you are sure that every patient knows what he is dealing with, what is going to get, what pills he's going to take, and how long is going to be the treatment. It is very important to know, and maybe you should find more easier language for the patients. And this is what we do from our side. We are trying to accommodate the information to the level of every patient we are talking and we are working with. Thank you.
Go ahead.
Just a small note, the companies love money, and the doctors, as far as I understand, do love statistics. And in terms of awareness, one cured patient, if we involve him into the awareness work, can at least talk about TB and teach about TB. His family, that's about, on average, 5 to 10 people. His colleagues, another 10 to 20 people. So all in all, let's say in Ukraine, if we have, what, about 100,000 cases per year? So that would be millions of people who get aware about the disease and how you can get it, and that it can be treated, and that it's not the end of life. So maybe we should keep in mind that this approach, this idea.
I want to go back to a couple of things, a couple of themes now that you have brought out. One is around the issue of language, not only in terms of communicating and educating the public and people with TB, but also the language that we use around describing people with TB as patients, as suspects, and the issue of stigma in particular, and how that is a challenge in working in the community.
Yeah, I would actually let the patient talk.
Ouais, merci beaucoup. Je crois qu'au Congo, l'expérience elle est tout à fait particulière. Souvent, quand nous détectons, nous sensibilisons des cas qui arrivent au centre de santé, les termes utilisés, c'est le cas suspect orienté. Et le suspect, c'est déjà un dangereux, c'est un criminel, c'est à confondre à un criminel, et ça pose problème. Et même aussi par le geste de la bouche, hein, une fois que, à certains milieux, l'infirmier sait que telle personne est infectée de la tuberculose, c'est par une simple geste de bouche. Hein. Il fait comme ça. Ça veut dire qu'il est atteint, il est infecté. Ça pose problème. Ça n'encourage pas la personne à continuer le traitement comme il se doit. Et même dans les quartiers, vous verrez des gens, quand vous passez, c'est des gestes. Et cela pose problème. Et donc nous avons fait un effort pour sortir les malades de cette clandestinité et témoigner haut pour dire que nous sommes des tuberculeux. Et nous pouvons aussi faire quelque chose pour qu'on ne puisse plus traiter les tuberculeux de la sorte. Et c'est ce que nous avons fait au Congo. Donc aujourd'hui, je peux passer à la télévision, à la radio pour dire « Je suis un ancien malade. Je suis là pour aider les autres à être comme moi. » Et donc, par mon témoignage, je peux aider les autres à suivre mon exemple. Et pourquoi pas à guérir aussi de la maladie. Et donc, c'est comme ça que nous agissons au Congo. Et ça porte quand même des fruits.
Thank you very much for your question. Well, it's true in DRC, again, our experience is quite particular. Because, for example, when we raise awareness on the population about this disease, as I said before, for example, when we are in a health center and that we have a person coming with symptoms, for example, we call these cases suspected cases, okay? So when you use this word, suspicion or suspected, everybody's thinking on criminal people, on people really very bad and very dangerous. And even the staff members use like a mouth gesture, like a kind of a secret language to tell each other that when a patient has tested positive on the disease. And even in the street, you can see people like pointing to each other when they know that someone's affected by the disease. So of course, this is not encouraging people to follow treatment and to speak out their voice. That's not helping at all. So what we want to do is to help these people out this hidden situation. We want to raise our voice to say that this is, well, a curable disease. For example, now I can be on TV shows, I can be on the radio talking about my experience, saying that I was a former TB patient, so I hope I'm helping other patients to become like me or to be like me, so that one day they will also be cured from the disease.
And then I want to come back to the point that Mesake made, and I think it was actually a very powerful point, that the disease seems to have become more important than the patients themselves. And I wonder what your thoughts are on how we can change that dynamic, what needs to change within the TB community to focus more on a patient and less on the disease itself.
When a patient is has left hospital, it is DOTS program, I believe there has to be something in place. What can the health authorities use it, rather than just either you use it or you lose it. As I've been saying, the TB patients group is a very effective group. As in the past few days, we've been seeing in the four-legged stool, one of them is the communities. And these patients are in the communities. We could use them to help out in the awareness program, as well as training them to become good counselors to the other patients.
And what about in terms of the health system? How would you like the health system to change the way it behaves to be more person-centered?
Yes, I believe that the health authorities has to focus on the patient as a whole, and what does that patient need. Sometimes the patients have to go through taking those pills, and it is depressing. Now, how are we going to handle the depression? Is there anyone counseling him or her in regards to that? So those are things. There are other few things that should be in place, not only just the DOTS program, in looking at the person holistically, in what way we can treat the patient, as well as help him to grow to become a very productive human being.
Yeah, and with all respect to public health approach, I think medical professionals should not forget that medicine must be patient-oriented and patient-centered. And there was a presentation yesterday talking about the ethics of DOT, and I'm glad that some doctors, some medical professionals actually care about the ethics and what the patients think and feel about their treatment. And you, as opinion leaders, may help a lot to the patient community in that. I know that, at least in Ukraine, on a national, on high national level, there is a good understanding of new approaches and new technologies and everything. The problem is when you go down there into the fields, you have doctors, you have nurses who prefer to stick to the old ways, you know, and would rather have the patients in prison, as a matter of fact, for like a 6 months up to 2 years, you know, and keep them inside those TB dispensaries and not let them out.
And one of the other things we were talking about yesterday when we talked about this was the issue of the numbers of pills and the burden it is for people to try to adhere to treatment.
As a personal experience, I'd like to say that it's absolutely necessary, even the quantity of pills. I think this is why we are here, TB activists, to ask and to support and to search for new regimens, to make the scientists find something that this patients takes only 2 or 3 pills and not 21, as I did for about 2 years. That's absolutely inhuman. So I'm always understanding people who are giving up the treatment. That's why here we need some new regimens. This is what we as TB activists are searching. We are asking for new regimens, for new therapies, to combat the new variants of TB. It is absolutely crucial. And as long as we don't have it, we can't blame patients that they are not following the treatment until the end. Relating to the activity of TB patient groups, I do think it is important. And as far as medical staff, doctors, nurses, they have plenty of time. I know they don't have time to counsel every patient. Let form a patient or patients group to do it, not to avoid their contribution in this activity, but open their doors and let the patient groups or TB activists or any organization which wants to deal with TB to do it. And I think the benefits will be great.
Yeah, particularly we do have fixed dose combinations in the market, and the patient organizations, the NGOs, can help persuade the governments and the authorities to get those fixed dose combinations into the market and let the patients have one pill instead of 4 pills, for example. I think that would help the doctors as well, and not only the patients.
We've all talked a lot about all of the contributions that communities have made and continue to make, mostly on a voluntary basis. So I want to ask all of you, what are your opinions about compensation for the work that communities do, and how are you sustaining your efforts? What sources of funding do you have? What do you need to keep doing this work?
Okay, I guess we're lucky. Because we still have the Global Fund project, the USAID projects that help us fund our activities in the country. But we do know that Global Fund will withdraw its funding sooner or later. So we actually started years ago working on the legislature allowing the government to pay for the services of the NGO, providing those social services to people in different fields, not only in HIV or TB or in medicine in general. And we are actually developing the standards of social work and care. We're a little bit concerned that NGOs wouldn't be complacent, I guess, right? Wouldn't be able to comply with those standards, but we're working on that as well, developing the capacity and training the staff of the NGOs. So hopefully one day all those activities will be funded by the government or local governments. I know in some places it has already started. And of course working with other donors, small businesses, big businesses, it helps too.
As a member of our national platform of NGOs active in TB, we started, we understand that Global Fund would not stay forever in our country. So we began to think about a mechanism to make people contract the services from the NGOs. Of course, it is going to be a process, a long process, but we should manage to do before the Global Fund ends. Until now, our organization our activities are funded from the resources of a Global Fund, and it is not of concern for the moment, but we should think for the future and elaborate this mechanism to be sure that our activities are sustainable and that by the end of any year we are not going begging for financing to continue the activities. It should be done on a regular basis.
Funding is very limited, but we've gone to look into the local governments who actually put in a funding, a budget for the locality, for those areas, in terms of the TB cases arising from those localities. But we know that the global funding is just up to 2019, and we have looked into areas working with the government as well as NGOs to see that funding for the awareness program in regards to TB is done in a proper manner.
Oui, merci. Pour le cas du Congo, ce que je peux dire ici, c'est que nous travaillons déjà avec Global Fund, mais c'est un financement qui a beaucoup de procédures, beaucoup d'exercices, beaucoup de gymnastique parfois, et qui nous mettent parfois un peu mal à l'aise, ça il faut qu'on se le dise. Mais nous essayons de travailler, nous sommes sous-bénéficiaires avec le projet Global Fund, et nous travaillons à l'Équateur, qui est une province aux dimensions aussi continentales, avec des routes un peu compliquées, mais nous sommes appelés à aller secourir nos frères malades là-bas. Mais nous avons également l'action d'Amiens qui nous vient en aide, mais ce n'est pas une agence de financement malheureusement, mais qui ponctuellement peut agir, peut essayer d'aider les communautaires pour plus de sensibilisation auprès de la communauté et pour des implantations de clubs de malades à travers la ville de Kinshasa. Nous avons également eu à travailler avec USAID à travers PATH, qui nous a aussi appuyé dans la formation même des anciens patients qui avaient intégré le club, qui ont appris les techniques de communication, comment communiquer avec la communauté, comment sensibiliser, comment orienter les cas vers les structures. Et ça nous a permis de faire un travail de qualité. Mais je crois que ça ne suffit pas là. C'est vraiment une goutte d'eau dans la mer, mais nous avons besoin plus de moyens techniques, financiers, pour arriver à faire plus que ce que nous faisons. Et ce qui est malheureusement inacceptable, c'est le fait que même quand le Global Fund arrive et vous dit, vous les communautaires, vous n'êtes pas capables. Vous n'avez pas les capacités managériales qu'il faut, vous n'avez pas les capacités techniques adéquates, vous n'avez pas. Et finalement, c'est nous qui sommes en face de ces malades qui essayons de faire quelque chose. Mais si vous ne nous capacitez pas, si vous ne nous donnez pas ce que nous voulons pour aider les malades, mais qui vont les faire à notre place? Parce que le personnel soignant au bureau, il n'a pas tout le temps. Et donc je crois qu'il y a la nécessité que vous qui êtes là, qui nous suivez en ce moment, comprenez que nous devons crier haut, nous devons essayer de faire comprendre que la communauté était un partenaire important aux côtés de la réflexion que le programme, de la réflexion que même tous les partenaires qui financent essayent de faire. Et je crois que ça ne doit pas s'arrêter là. Voilà un peu ce que je peux dire.
Yes, in Congo, in my country, we also work with Global Fund, but I have to say that it's quite, there's a lot of bureaucracy. We really need to, it's like kind of gymnastics, okay, because, well, and we do not feel very comfortable in that situation, honestly. But, well, we are working with them, we are receiving their help in order to reach some difficult provinces, like Equator province, for example. And then we also have the Action Damien, that, who's helping us for some specific and particular actions. This is not a funding agency, of course, but they are helping us in these specific situations, mainly in our awareness activities, also in implementing other clubs in the territory for former patients. Through Kinshasa also, and we also work with USAID through PATH, and we work with them mainly for educating former TB patients so that they are trained, for example, in communication techniques, in awareness techniques. Also, they are trained in order to properly accompany patients. So we have done a very good job. That's really good, but this is only like a drop in the ocean. So much more needs to be done. For example, we need more technical means for doing things. We need more funding, more money for continuing doing more things. And then I think there is one thing which is really unacceptable, is when you have these people from Global Fund telling you, well, when they tell us that we are not capable, that we are not able to do things properly, that we are not well trained, that we do not have the right skills. Well, at the end, we are in front of these patients. So if you are not giving this training, if you are not helping us, who other will do that? I mean, we are with them, so train us, help us working better. So I think that it's very important that you here in the audience understand that it's very important that we all talk very loud, and we say loud that besides the programs which are very needed, we all have to reflect on these questions to go beyond.
Thank you. And I think we talked a lot about this yesterday, was the need to capacitate the community organizations to manage the money, to do all of the administrative work that's necessary to then be able to do the valuable work that they do on the ground. We are coming near the end of our session, and I want to give all of our panelists just a few minutes to say their final words to this particular audience of things that they think are the key takeaway points that they would like you to get before you leave this room.
Okay, I'm happy to be here because I think this conference is a turning point for the Union. I think it's like one of the first times where the community voices are actually heard and loud, and they will become louder. It took the International AIDS Society about 4 conferences to understand that they have to involve the community into the conferences. It took a bit longer for the union to do that, but I hope that in Cape Town we'll have more patients, we'll have more community leaders, and dear doctors, you'll have to get used to it. You'll have to cooperate, and in the end, you will understand that it's great when you have patients helping you. As for the ideas that I would like for you to take home is not to forget that patients, your patients, can help you once they're treated, can help you in course of treatment. Bear with them, speak understandably, speak simple language, and don't forget there are fixed dose combinations. And the easier it is for a patient to go through the treatment, it would be easier for you as well to get great statistics for your high authorities. You know. Thank you.
I will add just two words. Increase communication.
There we go. There we go. Go ahead. Try again. I don't know if did everybody hear that?
Just 2 words. Increase communication.
I'd like to conclude. It's been a very long journey for me, 28 hours to fly from Fiji to Barcelona. So firstly, I'd like to thank the union for all they've done for the trip here to Barcelona, and it's been a great learning experience for me. Secondly, I would like to thank the Global Fund for their support in funding the new research program in Fiji, which is working very well. Thirdly, as we had said in the 5-day conference, communities play a vital role, and the TB patients, they do play a major role in that. And I'd suggest that the union could organize community leaders and former patients a conference to discuss and share ideas on how they tackle the issues in their country. And this could be a launching pad for the community-driven solutions. Thank you.
C'était un réel plaisir pour moi de prendre part du haut de cette tribune de l'Union pour parler au nom des anciens patients tuberculeux du Congo. Mais ce que j'aimerais dire à l'Assemblée, c'est une attention un peu plus particulière à la tuberculose plutôt qu'à Ebola qui bat les pleins actuellement. Et si on pouvait vraiment mettre beaucoup d'efforts, beaucoup d'accent sur la TB, je crois qu'on n'aura plus les longs traitements comme nous les avons. Nous n'aurons plus à consommer autant de drogue pour à la fin peut-être nous amener sous la tombe. Et je crois qu'il y a intérêt vraiment à voir les choses dans ce sens-là. Et peut-être un deuxième élément, c'est de vous demander, ce sont les mêmes messages que vous nous dites. Lorsqu'un patient est sous traitement, il ne contamine plus, il n'est plus contagieux. Et donc je crois que ce geste devait devenir comme ça. Et je crois que ça mettrait les patients à l'aise. Un peu plus de considération et d'estime. Et je crois que nous avancerons ensemble pour bouter la tuberculose hors de nos communautés. Merci.
Thank you. I want to say that this has been a real pleasure for me being here and talking here in front of you on behalf of, well, people in my country, but also as a former TB patient that I am. So what I would say that we should try to stress more TB than Ebola, for example. We are always talking about Ebola in these current days, but I think that we should stress the importance of fighting TB. This way, I think that we could have shorter treatments, that's very important, and we could also have less pills to take. We take some pills that sometimes you think that they will make you die because there's so much, so we could maybe take this approach. This would be the right approach for me, having shorter treatments and also with less pills. And then a second thing I would ask you is just to say and to spread this message around you that when a patient is under treatment, he can't, how to say, pass the disease to other people anymore. So he's safe. You should spread this message so that this gesture that we did at the beginning should be this one. Thank you.
Thank you. And I want to say a few words from Edith. I want to pick up on what Patrick was saying about Ebola. And Edith made a point in her notes that in Nigeria in particular, you know, that was affected by Ebola, the response was very rapid. It included mobilization of all sectors of society. It included a lot of work with social media, and the problem was solved. There was a sense of urgency. And I think we'd all like to see that same sense of urgency as we go out of this room, as the Honorable Minister of India talked about in many of his speeches while he was here. So I think that that's something to keep in mind as we leave this room, that we should think about this as an epidemic that can be solved and needs to be solved with some urgency. Then Edith made another comment that I think is maybe a nice closure to this session in thinking about the partnership that we have between communities and organizations, and in particular the technical organizations and the NTPs that are doing work in countries. When she was under MDR treatment, she said this. She started out saying, "I remember how devastated I became after I was diagnosed with TB. I was completely shattered. My world became dark and small. I thought it was the end of life for me. I cried hopelessly, even when I was told by the doctors that it was curable. I felt they were only doing their job, part of which is to console patients." Then, with the commitment of the technical partners, the NGOs, they gave me strong hope and really encouraged me. I want to commend the efforts of the partners, everyone that is involved in making this a reality. They really gave my life a leap. It was my first time ever seeing where patients are tipped to take their drugs, which also came free of charge. They are the reason for my speaking out and being here today. I would have given up a long time ago. On behalf of every TB patient that has received this TB leap, I want to say a big thank you to the partners. I want them to know their efforts are productive, their efforts produced me, and are still producing several me's out there, and it is highly commendable. So with that, I would like to end this session, and I would like to give a special thanks to the union for suggesting this symposium, this plenary session, and a special thanks to Stacy Stender for making this happen. And thanks to all of you for your attention, and to all of the panelists for the amazing work that they do on the ground every day trying to help people with tuberculosis. Thank you.